Welcome to my channel once again. Today we are going to look at antihypertensives.
So before we begin, let's do some few introduction to the topic by starting with what is hypertension. So hypertension is a chronic condition in which the systolic blood pressure is greater than or equal to 140 millimeters per mercury and the diastolic blood pressure is also greater than or equal to 90 millimeters per mercury on repeated measurements, meaning these values are checked and then are met on repeated measurements, meaning they record the value frequently according to hospital protocols, and then the individual has a systolic blood pressure greater than or equal to 140 and that of the diastolic also to greater than or equal to 90 millimeters per mercury. So now let's look at what are antihypertensives. So anti means against, so these drugs are against hypertension. So antihypertensive drugs are medication used to control high blood pressure. That's very simple. They are used to control high blood pressure.
So now let's look at some factors influencing blood pressure. So for the blood pressure to be high or low, it will depend on these factors. We have cardiac output, that's the amount of blood pumped out of the heart. Then we have peripheral vascular resistance, that's the resistance in the blood vessels in our peripherals. So basically we can look at vasoconstriction being one of the resistance in the peripheral vascular system. We can also look at blood volume. When there is an increase, blood volume actually causes an increase in cardiac output as well. So we have blood pressure, which is equal to cardiac output multiplied by peripheral resistance, being formula to determine what blood pressure. So let's look at a brief pathophysiology of hypertension. So one, we look at defects in the organ systems, then mechanism controlling cardiac output, then total peripheral resistance. So hypertension may result as a result of a defect in the organ system which will lead or affect the mechanism controlling cardiac output as well as linked to peripheral resistance. So we have defects in the organ system such as the heart, kidney, brain, and the blood vessels. For the kidneys, there are lots of presentations I've done previously relating to how it regulates blood pressure. So you can reference the previous videos. The rest of the organ structures over here, videos will be made on them later and you can actually get a view of them. So a defect in these organs will result in failure of the body to control blood pressure and it will lead to an elevated blood pressure at the end of the day. Therefore, simply all antihypertensive drugs going to be studied under this presentation will target these main structures: the heart, the kidney, the brain, and the blood vessels. So now let's focus our lens on the main topic of the day, the drugs, the antihypertensive. So we have them outlined over here. We have the ACE inhibitors, which is angiotensin converting enzyme inhibitors, which usually end with the pros. So we have the lisinopril being an example. Actually, presentation have been done on this in my previous slides. You can review and know how ACE works. Then we have the angiotensin 2 receptor blocker, which usually end with the statins. So we have losartan. We have calcium channel blockers, usually end with the pine. We have the amlodipine. We have the diltiazem and the verapamil and the nifedipine. We will delve deep into that later as we progress. We have the diuretics, example being the thiazide diuretics, which an example being the hydrochlorothiazide. Then we have the beta blockers, usually end with the olor. So we have metoprolol, atenolol, etc. We have another class of diuretics, which is the loop diuretics, which end with the ides. So we have furosemide. Then we have the potassium sparing diuretics, which is another class of diuretics as well. An example being spironolactone. Then we have the alpha 1 blockers. which ends with the osins. So we have prazosin, then we have doxazosin, then we have the central alpha 2 agonist. Clonidine and metadopa are usually used in pregnancy-induced hypertension. Then we have the direct vasodilators. Most common use is the hydralazine. Then we have the direct renin inhibitors, aliskiren being an example. Then we have the alpha beta blockers, which are non-selective. So they go with the beta blockers, with the ending being the LOL, even though they block beta receptors, but they have influence in the alpha receptors as well. So they could be classified with these ones, but because the beta blockers in 5 are specific, they focus on beta 1 and beta 2. That's why they are separated in this category.
So let's look at the subdivision of the pharmacological management based on first line agent and then second line agent. Actually, the first line agent structure is done not for emergency cases per se. This is for a hypertensive patient who is a bit stable, not for an emergency case where you require more of an IV route like labetalol and then hydralazine. So here it's more focused on patients who are hypertensive alright but are a bit stable. So we have our first drug being angiotensin converting enzyme inhibitors, which usually end with pril. Example being lisinopril. Then we have the angiotensin 2 receptor blockers, always end with Satan. Example being losartan. Then we have the calcium channel blockers, and then subdivided into dihydropyridines, which usually end with pine, P-I-N-E. So we have amlodipine, nifedipine. Then we have the non-dihydropyridines, which is the diltiazem and the verapamil. We'll actually delve deep into this as we go on in the presentation. Then we have thiazide diuretics, which is example or a class under the diuretics, which we have its example being hydrochlorothiazide.
So we have the second line being the beta blockers, usually end with the law. So we have metoprolol, atenolol. Atenolol is more common in the system. Then you have the non-selective, which is the combined alpha and beta blockers. Carfidinol is an example because they have influence on alpha and beta blockers as well. Then we have potassium sparing diuretics, spironolactone being an example. Then we have the loop diuretics, furosemide, ending with the IDE. Then we have the alpha blockers, which is specifically um, binding to the alpha receptor, usually end with the sin or osin, or you can say zosin. Then we have the centrally acting alpha 2 agonists, clonidine and metaldopa. Then the direct vasodilators such as hydralazine. Then we have the direct renin inhibitors, which is the alaskrin.
Thank you for your time. That's all for today. Meet you next time on the next presentation.